The plan for tonight is I'm just going to have a quick look at the topics that have come up so far in the final FRCA in the last few years. A little bit about exam tips, but mainly for the CRQs because they're the new ones. And then I've just chosen 4 topics that have either been answered not so well in the past few years, or one kind of slightly odd topic that is a new topic in the literature. So we'll run through that. So as you can see, there's a little bit of a mix of all. These are from the CRQs over the last few years. They also come up quite a lot in the SOEs and in the OSCE as well. They're quite easy. And actually the CRQ, the structure of the CRQ question now loans itself quite nicely to being an OSCE question as well. Like a SOE type question. So as you can see, people do pretty well on asthma and traumatic brain injury, so that's good. But all the others are definitely below 50% pass mark, and so I suspect that these ones are all ones that could be repeated again relatively soon, because they're relatively kind of commonplace in ICU topics. I think the APRV one was a bit harsh, especially as people have only been really using it for the last year properly. But hopefully you won't come across that again this year because it's already been done. So just for, again, I know some of you are doing the SOEs, but for the people that are doing the CRQs, you'll have done way more practice ones than we ever did because they're a new topic, they're a new type of question. But I've had a flick through the examiners reports, and they're fairly consistent in saying that the problem is that because it's now such a structured question, people are failing to answer this specific question that is asked, and it gives you the points and the number of points per question, and people are failing to prioritize those, so are trying to shoehorn lots of answers into a 1-point question and not getting down to the 4 or 5-point questions that come later. So I just have that in mind as you're practicing. They also continually say there's poor knowledge of clinical sciences, which I think is something they've said for years and years as well, so revise them as well. Again, just for the people that are doing the CRQs, there's the Royal College website always has good questions, and over the years, both for FICM and for FRCA, I can say that at least 2 out of my SOE questions have come from published by the Royal College questions that have previously been published by the Royal College. So I really would have a look. They've got the asthma one there, they've got the delirium one there, they've got the TBI one. So I would definitely look at those, because you'd be a bit sad if you came out the exam and realised that you could have seen it before. So the 4 topics I've had a look at, I thought we should look at tonight, is one is tracheostomy. Incredibly pertinent at the moment because there are so many more patients with tracheostomies in ICU, and ICU is still being cross-covered by more junior staff, by staff that are less familiar with tracheostomies, and also people, there'll be more out on the wards, so therefore more potential for emergencies. Refeeding is a topic that's done badly both in FRCA and FICM actually, so it's quite an easy topic with some pathophysiology to talk about. Pancreatitis, nutrition and ARDS, that's just a way of covering 3 big topics together. And then this 4th topic, which is hot off the press and very random and something I would never have looked at myself before an exam, I think. So even if we just run it through tonight for the first, and you never look at it again, at least you've heard of it at some point. So like I said, in 2019, the tracheostomy had a 47% pass, which on that particular paper was the lowest for that paper, which shows how good the pass marks were on that. I think that's quite unexpected for a normal year. But the college have said that tracheostomy care has been highlighted in a number of patient safety bulletins, and really candidates should know more about this and in more detail. So we'll have a little look. So we will go through indications, benefits, contraindications and complications of trachees, which is all relatively straightforward. The CRQ for this has very specific questions about assessment of patency, immediate management of blocked tracheostomy and management of worsening hypoxia. Now, if this comes up in an SOE, then you can talk about it and you can tick off the boxes. But in a CRQ, they're very specific about what parts of the algorithm go into which which different bit, and actually it's quite difficult to work out which bit should go in where without repeating yourself. So I've made an attempt at it, but as I said, I can't promise that that's the actual answer for the exam. There's also a BJA article from 2019 that's definitely worth looking at and to help with this. So indications for tracheostomy, again, there are thousands of indications, or we could reel off a few, but if you can classify them, then you would, in an SOE, definitely get through it pretty nicely, and in a CRQ, it probably helps you cover all your bases on a points-based answer. So indications for tracheostomy, so airway obstruction, urgent or emergency airway obstruction such as burns or laryngeal and facial trauma or anaphylaxis, prolonged mechanical ventilation and weaning from that. So we are tending not to put so many tracheostomies. People are ending up with tubes a lot longer at the moment, especially in the COVID setting, but generally we would look to use tracheostomies within the first couple of weeks of intubation, of ventilation in ICU, with the proviso that we expect that the ventilation period, invasive ventilation period, is going to continue for more than the next 3 days or so. The provision of pulmonary toilets, so patients that don't have enough cough, so either weakness on ICU or neuromuscular problems, bulbar palsy, unable to cough themselves. For airway protection, so again, people that are unable to maintain their own airway, either because of their ICU stay or because of their neurological injuries. And then part of the surgical procedure. So this is where tracheostomies can come in, both in an ICU part of an exam or into an anaesthetic question as well, as you would be fully expected to be able to talk about them as part of surgical procedure as well. So the benefits of tracheostomy, so not just the indications, but they do have a benefit in ICU. So the earlier you can remove a tube from a person's mouth, that reduces the laryngeal trauma, it reduces the amount of sedation that's required, because clearly it is much less stimulating to have a subglottic tube rather than through the vocal cords. It facilitates weaning of ventilation, and what I think most of us could imagine is much nicer being able to have improved oral hygiene. It also enables patients to be rehabilitated and communicate better, and that you noticeably see that difference when people's sedation is down and they're able to mobilise around the unit or sit in a chair, and then SLT teams are able to come in and help with communication. And then all of this overall contributes to reduced length of stay on ICU if there are no complications. So looking at the contraindications, so again, this is where this could cross over to an anaesthetic tracheostomy list. So you could be asked to assess someone for a surgical tracheostomy from ICU. And unless you work in a hospital with a head and neck team, the chances of someone needing a surgical trachea in ICU is usually because they're deemed to be difficult for one or other of these reasons. So obviously in the contraindications, if the patient refuses, if they're awake enough to refuse, then you can't do one. And timing, as I said, if you think the patient is not going to need ventilation for much longer, or maybe if they're more likely to die in the next 48 hours, you might not do a tracheostomy. Their airway, so airway factors. So I think most intensivists would do a percutaneous tracheostomy in an obese patient, as long as the rest of their anatomy seemed reasonable. But someone with an unstabilised C-spine fracture with unfavourable anatomy, such as a short neck, reduced neck movement, abnormal thyroid or aberrant vessels when you look with an ultrasound, or not being able to palpate the first two tracheal rings, or someone with a known difficult airway, those patients we would refer to for a surgical tracheostomy. We probably shouldn't be doing them in patients that have got high oxygen requirements. In the paper it says less than 0.6, but I think in reality we would do it. We would wait till someone's oxygen requirements are even down to 0.4, sometimes 0.5 at a push, but usually less than 0.4. And then clearly, if you've got a local infection over the site of the tracheostomy, you shouldn't be putting one in, and coagulopathy is a relative risk depending on the need for it and the degree of coagulopathy. Complications, hopefully these are ones that you've spoken about before and you've thought of a structure. As with all complications, there's early, short-term and longer-term complications, all of which are relevant in ICU and anaesthetics. I guess I said the only thing I noticed, and I'm not going to read through this massive table, and again, this is on the BJA article, it has pneumothorax in the short-term complications, but I've also put it in the early because clearly you can create a pneumothorax during the insertion of it. So if you can't reel off at least 3 or 4 of those per section, I would get that straight in your head. As I said, the specific stems of the CRQ question is quite hard to pick apart, and it's all based around the tracheostomy algorithm from the National Tracheostomy Safety Project. So hopefully you've all seen this before. It's likely that you all have this on your ICU. I know some ICUs have ICU specific algorithms, but I think in a national exam it would be reasonable to expect you to work off this algorithm. You could always talk about local protocols, but the answers, I guess, would be based off the national guidelines. So when I had a little look at this, I felt that the patency question was very much looking at your examination of the trachea to see whether or not it was patent, rather than the steps you would do to treat that. So because otherwise it overlaps with the management section. So use of waveform capnography obviously gives a, if you have exhaled carbon dioxide, it indicates that you've either got a patent or at least partially patent airway. You then can skip down to the next part of the trachea algorithm, which there nicely says for you, assess tracheostomy patency. So in this section, as I said, it's hard to pick apart the parts that are the management part and the patency part. But I felt that listen via waveform capnography, can you pass a suction catheter down and using the Mapleson circuit to assess breathing and seeing the breathing being there is the assessment of patency. The next question was about the immediate management of tracheostomies. And again, it's basically picking out the other parts of the algorithm and putting those in. So I think what this question highlights is that although you'd be fully expected in real life to hold that algorithm up and someone talk it through, because we all know that human factors are really important and we need algorithms to stop us making mistakes. Clearly in the written exam at least, and probably in an SOE, they would like you to know the more pertinent parts of that algorithm. So I would take some time to look at that. The worsening hypoxia, again, at the bottom of the algorithm, it just tells you primary and secondary emergency oxygenation, which I must admit, I don't think I've ever actually read that the top titles until I was answering this question. But it is what you would always do, which is provide oxygen and airway support from the oral route initially, whilst covering the stoma of the tracheostomy that you've removed, and then to consider tracheostomy ventilation if that wasn't possible, and then to move on to intubation of either the oral route or the tracheostomy stoma, depending on your skill set and your equipment that you have. So that's just that summed up there. So that's just a brief run through of tracheostomy. As I said, it's really just based on those guidelines and that paper, but knowing the tracheostomy guideline well I think that's been highlighted quite pertinently in those questions. So refeeding syndrome, again, not the best pass, and definitely a topic that when I got asked it in a practice SOE, I completely fell apart in, because you think you just have to give Pabranex and that's it. And I hadn't really thought about the pathophysiology that much. So, and I think it's been definitely asked a few times. It consistently gives a low pass mark, and so is one that is an easy question to ask again. So I would look at it. The comments from the examiners were that candidates need to be more specific, so not just, well, they've got low electrolytes, so you need to give Pabranex. It was a bit vague about things like parenteral nutrition contents and requirements for the day. So we'll have a quick look at the pathophysiology and clinical features. I'll give you a rule of thumb about PN, and then talk about patients who are at risk of refeeding and how to manage it. So refeeding syndrome is a syndrome that results from reinstitution of nutrition to patients who have been starved or not had that nutrition prior to it starting. The pathophysiology is that you have chronic malnutrition, and that pushes the body into protein catabolism and phosphate depletion, although your phosphate levels, your serum phosphate levels, don't change and they remain normal. You then, once you get a sudden carbohydrate load, it results in insulin release as normal, which activates various pathways which require marked uptake of phosphate, magnesium, and potassium. So these are glycogen synthesis, fat synthesis, and protein synthesis. By activating those pathways, like I said, you get a massive draw-in of your phosphate, your magnesium, and your potassium. And the hypophosphatemia results in phosphorylation of carbohydrate compounds. It results in depletion of ATP, and therefore goes on to cause cellular dysfunction and also decreased oxygen carriage with hemoglobin because of the lack of phosphate in the buffer systems. And it also increases the urinary magnesium loss. So it's primarily the hypophosphatemia that drives the problem as a result of the insulin release and the activation pathways. I think most questions, if you said those 3 sentences from a pathophysiology point of view, that is enough. They don't want more detail than that, but it's just important that you know those bits. So clinical features, again, systems-based, whether you're in a CRQ or an SOE. So cardiac-wise, you get arrhythmias and cardiac failure. Respiratory muscles are weaker, you become ventilator dependent. The neurological symptoms are quite wide-reaching and can be fairly devastating. And then gut side effects are caused such things such as constipation, vomiting, and anorexia. You're at more risk of infections, you become weak, and you can get osteomalacia. You have huge, as we've already said, electrolyte derangements, you have massive fluid shifts, and therefore huge metabolic abnormalities as well, with significant acid-base disturbances. You get abnormal glucose metabolism, and as we said, the low phosphate, magnesium, and calcium, as well as a thiamine deficiency. So all pretty bad. So parenteral nutrition, not something we use on every patient, and there are plenty of papers that you will have heard about, or you will see in things that when talk about parenteral nutrition, that basically says we don't have to do it, and we don't have to do it for most patients for at least the first week of ICU. However, with patients who are at risk of refeeding syndrome, it should be something you consider and you discuss with the MDT, specifically the intensive care dietitians, because they're very used to this. The complications of starting PN is obviously access related, so it has to be through a central vein, so either a PICC line or a central line. And if you are in theatre and you're putting in a line for someone, this is a good, a good tip generally, or nice thing to say in your SOE, then just put a label over and reserve a line for TPN with one of the central line ports, because that's incredibly helpful back on ICU. Liver-related complications include hepatic steatosis, cholestasis, and rarely, but can be, liver failure. There's an increased risk of sepsis, increased risk of hyperglycemia because we're infusing glucose, and because of the volume of PN and the fact that it's made up of electrolytes, you can end up with fluid overload and electrolyte imbalance if it's not monitored correctly. So one of the questions in the CRQ was to give the criteria for people who are at high risk of developing refeeding syndrome. And they were very specific about saying it wasn't about individual pathologies, it was about the person that that pathology was affecting. So this table is from the NICE guidelines. They were they're from 2007, but they're updated in 2017. So I think these are the most up-to-date ones. But clearly you have to have a BMI that's relatively low. There's a percentage weight loss over a time period, and for how long you've recently not eaten for, sorry. So that table, again, I would commit some of those to memory, because they're the kind of specifics that they were upset about people not knowing previously. Generally, though, you can group those into 3 groups of people who are people that have got a decreased intake, so people who are otherwise unwell, have eating disorders, alcoholism, depression, post-op, prolonged milk by mouth period, and chronic malnutrition. People with decreased absorption, so people with short gut, malabsorption syndromes such as IBD and celiac, and then increased catabolism, so any of our patients basically with malignancies, inflammation. So management of refeeding syndrome is very specific, and again, this is a comment from the examiners that people aren't specific in their management. So the first thing is to identify at-risk patients. The second one is to have specific intensive care dietitian-led care, and that you have to make sure that you supplement electrolytes and vitamins appropriately. The way you do that is to monitor the patient, which we'll talk about in a minute. And the main thing is to avoid, another main thing is to avoid fluid overload, because like I said about the volume of the PN. You have to be cautious with your carbohydrate administration. And again, specifically, this was mentioned by the examiners that people weren't quoting the number. So at the current guidelines is that if you have someone who's at risk of refeeding, you should start at 10 kilocalories per kilo per day of carbohydrate administration, and slowly increase that over the next few days up until a full administration at a week. However, if someone's at severe risk of refeeding and their BMI is less than 14, you might have to start even lower to 5 kilocalories per kilo per day. So again, 5 and 10, not massively hard numbers to remember, but I know that you have thousands of other numbers to remember. But it's worth just writing that down or saying that if you are asked about it. Monitoring obviously includes all your electrolytes, especially phosphate, potassium, magnesium and calcium, checking your thiamine and trace elements as per your dietitian guidance. It's usually weekly or twice weekly, and then monitoring blood sugars, which is done hopefully by the nurses on ICU during the day. I think the other question about monitoring of blood sugars is what your the range of blood sugars that are acceptable in ICU. And again, it is very much demonstrated that a not too strict range is appropriate. So 4 to 10 is appropriate. Anything more strict than that, you risk hypoglycemia. So that's the monitoring, even someone on parenteral nutrition. So third topic, sorry, I'm racing through because I feel like we need to get some of this done. So pancreatitis, nutrition, and ARDS. This is a huge question, but all of these 3 things are quite common, especially now, sadly, on ICU. So again, this was 3 years ago. It was 37% pass, so it would not surprise me if it was repeated fairly soon. And the examiners were also surprised at how low the pass rate was for the question. So again, a bit about the etiology of pancreatitis, which is what was specifically asked about in the exam, diagnosis and severity, a bit about pathophysiology, because again, you just need a couple of one-liners of how to get that out. Talk about the management of acute pancreatitis, which I think, to be honest, most people know from F1 onwards, but it's getting it in the order mainly that's written in the BJA articles. A bit about nutrition and pancreatitis, and then some ARDS at the end. So pancreatitis, again, can be divided into obstructive, systemic or parenchymal causes. So I think it would be wrong if you're in the UK and you wrote a an answer about cause of pancreatitis, you should write alcohol and gallstones. So that's coming out of that classification system, but obviously gallstones are part of the obstructive picture, and alcohol can count the parenchymal section. I think other things you could think about, or you should write about, are malignancy, potential trauma, including ERCP. And then from a systemic point of view, we've got things like hypoxic or ischemic injuries. So for example, post out of hospital cardiac arrest patients, drugs also cause it, steroids, hypothermia, so patients who have either had bypass or other reasons for hypothermia. And then you go right down to the scorpion bites right at the bottom of your surgical sieve. Unless you live in a country where scorpions are a common cause of pancreatitis, I would probably skip that in your 3-point answer in your CRQ. So diagnosis of pancreatitis, I must admit I didn't know this until I read the book, until I read the paper, but very specifically it says it has to be abdominal pain, raised enzymes and imaging consistent with it has to be 2 out of those 3 things, which I guess is what we do, but I didn't know they'd gone that far to classify those 3 things. And that's the Atlanta classification, which I'd heard of. The severity scoring, so there's loads of scoring systems. Again, the Atlanta classification is one of them. There are the ransom criteria. There's ones that are based on age and clinical features. There are ones that are based on purely on radiological findings. The limitations of most of them is that they're scored at 48 hours, and clearly a lot of people can be very unwell within 48 hours. So you've lost your scoring has already been done for you once they're in ICU. And the CT based ones, as we know, often CT images don't correlate with how sick or unwell the patient is in front of us. So it's not a perfect system. The pathophysiology of pancreatitis, there's 2 phases. The first is you get systemic inflammation due to the host response. And this can result in, again, like any form of systemic inflammation, for example, sepsis, can result from either nodus organ dysfunction all the way to multi-organ failure. You then develop a later phase, not necessarily late, but later phase with local complications. And again, this can be with or without organ failure. So these include things like necrosis, acute peripancreatic collections, pseudocysts, vascular complications such as splenic or splenic vein fibroses. The most concerning one, like probably, is necrosis of the pancreas. But again, it's more about whether or not there is whether the degree of organ failure that comes with. So management of pancreatitis, one of the CRQs is what is the most important part of the management of pancreatitis? And the answer is fluid resuscitation. And they talk about it in the BJR article quite specifically. I say specifically, there's no absolute guidance of how to resuscitate pancreatitics. There's no trials or anything that tells you what to do, but it does talk about how high risk they are for massive fluid loss. So initially they come in with vomiting or diarrhea, and then they've got their capillary leak, and then their insensible losses from their fevers and their tachypneas. So they have their initial need for resuscitation, and then their fluid balance becomes really tricky because of their ongoing capillary leak. They are vasodilated because of their inflammatory response, and they third space massively. They have huge electrolyte shifts and acid-base balance shifts, as I'm sure you've seen before. So the fluid resuscitation and electrolyte and volume status rebalancing is the most important part of management. Sadly, by doing that well, you often end up with organ dysfunction of other parts, so we'll come on to that. The next thing I think is what is as important really is symptom control. So a lot of the patients come in with severe pain, and often that is what ends up them requiring intubation and ventilation in ICU, is that they cannot cope with their respiratory function is so limited by their pain. But as soon as they come in, they should be prescribed IV paracetamol and a PCA if possible, and that may help or may prevent them requiring intubation, not non-steroidals though, please. From an organ support point of view, every organ can be affected by pancreatitis. So respiratory wise, as we've already said, you can have huge capillary leak, so you end up with a edematous lungs. You have a huge fluid burden, a fluid resuscitation burden, and then that pancreatitis is also one of the main causes of ARDS. So often patients end up on at least high flow nasal oxygen, if not intubation for this. Cardiovascularly, the requirements are usually vasopressors because of the vasodilatory shock and the leaky vessels. And then renal management, again, is based around electrolyte imbalance, fluid shifts, and acid-base complications. The management of local complications may or may not need tertiary referrals. So again, that's something I'd mention. It has to be discussed on an MDT level, so radiology and surgical teams and sometimes interventional radiologists about what may be needed. So for example, like I said, examples of the local complications could be thrombus, it could be bleeding, it could be collections or necrosis. So those are variably managed depending on how sick or the patient is and where the patient is as well. So feeding and pancreatitis, ideally you would feed via an NG and give enteral feeding, but they are high risk of non-absorption or it could cause worsening of symptoms of pain. They're at massive risk of refeeding syndrome, either because of the source of their the cause of their pancreatitis, or the fact that with pancreatitis they become malnourished. And as I said, their preference is enteral feeding because that causes, it provides gut protection, and PN puts them at increased risk of infection, which they're already at risk of. So try it. Sometimes you end up having to, I'd mention NJ feeds as well, NJ tubes, but that's a later down the line as well. So ARDS goes quite nicely with pancreatitis, but it's also a question itself. The last comments from the examiners was that it was a surprise that the pass rate for this question was so long, that the management of ARDS is fundamental to ICU, and that most marks were lost by not being able to list the diagnostic criteria, and that it seemed to be that people didn't know about the Berlin definition. So again, there's a really good ARDS article from 2017 in BJA Education, and I would urge you to read it because it's really well summed up, and it's the same as in any book that you'd find. So learn a definition. It doesn't have to be the full written down one, but one that involves acute, diffuse, inflammatory, and hypoxia. If you can say that, then that starts you off in a good way of answering your question. Remember the Berlin definition, so it's based on 4 criteria. So the timing of the onset, so that's within 7 days. Imaging, so it doesn't have to be CT, it can be chest x-ray, but imaging showing bilateral opacifications, and that the origin of the edema isn't purely cardiac. So that's a change in definition over the years, but it can be as long as it's not purely cardiac, and an echo might be needed to determine that. Oxygenation ratios are important. So to determine the severity of ARDS, but also in oxygenation, a patient has to have a PEEP of at least 5, which is pretty much everyone in ICU, and they have to be ventilated. It doesn't have to be invasive ventilation, it can be non-invasive ventilation. I would urge you to have a look at that paper. Again, the pathophysiology that they require, there's a lot of words in there, but it's essentially 3 stages. One that's an exudative stage, so it's protein-rich fluid leaking out of the lungs and causing alveolar capillary membrane damage. You then get to a proliferative stage where you get fibrin deposit. The microthrombus formation happens in both at stage 1 and 2, and then there's a fibrotic stage at the end, which doesn't always happen, and it happens a bit later on. It's fibrosis of the lung tissue and therefore irreversible changes. So again, I think pathophysiology questions can be quite scary. We don't spend a whole load of time relearning pathophysiology, but you can, these articles do have them in quite a succinct way. There's a very specific part of the CRQ that asks about ventilation rather than oxygenation strategies. So I've just written them down here. I think that the important thing to remember is oxygenation is different to ventilation. So oxygenation includes things like inhaled nitric oxide and ECMO, whereas ventilation, they don't count for ventilation. So, sorry about my cough. It's important to remember things like lung protected ventilation, neuromuscular blockers, the things that you do all day, every day, and are the basis of ICU in the beginning of your answers. So very briefly, because I promised Toby I'd be a minute slower than I am, I read these articles today and thought probably they should go in because it's a random topic. They say by definition there's very few people, it's less than 0.5% of ICU admissions, but there's an article from October and an article in November in the BJA Education, which is usually, if you look at the history of publications and exam topics, they do tend to come up. So if you have a look at it now, you might not need to revise it again. Essentially, skin problems in intensive care are rare but have a high mortality, and they're often associated with infections, but you can get the primary dermatological emergencies as well, and people die because of sepsis and multi-organ failure. So they're a general problem. They are a multi-organ problem. So all your normal ICU care is really important, but actually the management is very akin to the management of burns. So hopefully if you read this article, a quick flick through now is also helpful in the management of burns. I think if you're taking the article very much focused on history to try and help the diagnosis of the skin conditions. So they're talking about flu-like symptoms, systemic symptoms that may lead you to diagnose the skin symptoms, so neurological and mucosal symptoms. A bit about etiology, so medications, bites and travels abroad, and whether or not someone's got an underlying condition or they're immunocompromised. Clinically, it's, as I said, it's very much like burns, and it's about fluid and electrolyte loss. Mucosal involvement, again with burns, you want to know whether or not there's mucosal involvement, and they use things like the rule of nines and the Lund chart to help assess whether or not, to help assess the body surface area affected. They do the same things like bloods and cultures and biopsies as required to help with diagnosis. And the management, it basically could be talking about a burns patient. So referrals to burn centre, it's more than 10% body surface area affected, barrier nursing and prevention of to reduce the risk of infection, because they're at massive risk of infection, but given that their skin is so damaged. Thinking about intravenous and intra-arterial access, which will be difficult, and to do it in areas where the skin is hopefully not as badly affected. That fluid therapy is problematic and management is hard, and that you should follow the Parkland formula as you do with burns, and that to caution with handlings, as with severe burns, there's a chance that just by touching the patient or using blood pressure cuff that you could cause serious damage to their skin. Analgesia is really important because this will be incredibly painful. Nutrition obviously will help with their recovery and is sometimes hard to do, and they're at massive risk of infection if you're using parenteral nutrition, and it has to have a degree of multidisciplinary involvement because of all of the above. I think it's probably best that we don't go through all of these individually. Essentially, it's split into infectious conditions, which are necrotizing fasciitis, cellulitis, and toxic shock. They seemed more focused on toxic shock syndrome in the article, so worth having a little look at that. The drug-related ones, they talk about Stevens-Johnson and toxic epidermal necrolysis and the spectrum between the two. And then, as well as this drug rash, eosinophilia and systemic symptom syndrome, which is a bit of a mouthful and probably unfair to ask you in an SOE. And then there's immune modulated ones as well. So as I said, it's very dry reading. It's a bit like reading up about burns, but it's a new topic that's just been put out, so high risk of being in an exam. As Toby and Lauren said, we'll if you want to ask any questions, then feel free to send them to them, and we can look through them and send out an answer release or something, so you can see all those. All of this stuff is from easy to access stuff, so BJ education or national guidelines. But if you want the slides, then I'm happy to send them to Lauren and Toby as well, with the comments underneath. So in summary, we focus mainly on ICU topics that haven't been done that well, but are also relatively broad. They're common problems, but then with the skin, it's a bit of an area of expertise as well. I'd really recommend the BJ education articles. I say that, I know there are thousands of them. And just think a little bit about exam technique, because as someone that's done it more than once, it is the technique that ends up being the most helpful thing, I think. And there's some references.
Thanks, Mel. That's really, really kind of you. Thanks, Mel. That's really, really kind of you. We well, that's fantastic. That's the first lecture done, guys. So please go off and have some supper or relax, and hope you don't have too much more revision to be done tonight. We will see you tomorrow for pain topics, which is done by Dr. Andy Grant, who's one of our pain specialists down here in Bristol. Lauren's just typed onto the chat forum, but if you'd like the slides, just email us through onto the email that you contacted us to get the links, the Zoom links sent out to you, and we will endeavour to try and get those sent out as soon as we can. But Mel, thank you so much, and thanks to you all, and guys, good luck for it all, and we'll hope to see you tomorrow night.
Good luck.
See you later, guys. Bye bye.
See ya.